Good afternoon. We just ended so that it automatically filters people over into the next session. So just give me 1 second. Matt Dull from Artia, who's going to talk to us about Medicaid and all the changes. Thanks, Matt.
Okay, thank you, Marla. So good afternoon. My name is Matt Dull. I am the Chief of Operations here at Artia Solutions. For those of you that aren't familiar with us, we are a Medicaid consulting firm composed of former Medicaid pharmacy directors, administrators, as well as some pharma industry staff, and we provide Medicaid consulting for various individuals, various manufacturers, various entities within the pharma spectrum across Medicaid. Our specialty is Medicaid, so here today I'm going to provide you with a Medicaid update. It's a pleasure to be with you. I've been fortunate enough to participate in several of the NHF conferences and provide Medicaid updates. I hope that the material that I share with you today is useful and provides some good information and insight on what's going on in Medicaid and what you could possibly expect to come in Medicaid. A little bit of background about myself. I've been in the Medicaid industry for over 22 years as a government employee in Florida Medicaid, also with the Florida legislature, where I was responsible for developing Florida's Medicaid budget for a number of years for the Florida Senate. And then I've been serving in a consulting at Artia Solutions for the past 11 years in this capacity. Hopefully today, the information that I share with you will give you some insight on what's going on in the Medicaid realm of business and how it may either directly or even indirectly affect the hemophilia space. So let's get started. So the information that I have to share with you today, just a quick agenda. We're going to talk about Medicaid enrollment impacts based on COVID-19. I'm sure there's been a lot of discussion around impacts of COVID, and segue into what's going on in state budgets, again, particularly what we're seeing and hearing on Medicaid realm. Then we're going to kind of switch gears and talk about some of the things that are going on in across the states in terms of some recent trends that we're seeing, talking about states that are doing what they call high-cost drug reviews, Medicaid single preferred drug lists, and carve-outs of pharmacy benefits away from managed Medicaid plans, and how they may impact hemophilia factor coverage and reimbursement. And then we're going to talk specifically about hemophilia factor and hemophilia coverage as it relates to these PDLs and how states are moving more towards managing the hemophilia factor and the agents into classes on these PDLs. Talk a little bit about pricing and spending and give you some updates there from some former presentations that I've provided with regards to hemophilia, and specifically look a little bit at the trend report that was released by Magellan. Then we're going to talk a little bit about what to look forward in 2021, more single PDLs and carve-outs to come, and what states potentially may do with their budgets, and then some pricing and pipeline information about some of the drugs. And then we'll stop there and do some Q&A. Got a fun-filled agenda for you today. So we're going to begin today talking about Medicaid enrollment and the impacts associated with it from COVID-19. Many of you that's been in the Medicaid space know that Medicaid is actually counter-cyclical when it comes to enrollment, meaning that when the economy, the U.S. economy, goes into decline, Medicaid enrollment will increase, and vice versa. When the United States economy is doing well, Medicaid enrollment is usually flat, or even oftentimes it declines. And so it can't be more evident by looking at the chart on the right of this slide. It provides an excellent depiction of this cycle. As you can see over here on the left side of the chart, when looking at the chart from left to right, you see that enrollments were flat and declining during the period when the country was experiencing some excellent economic growth from July to around January 2020. But however, beginning around February 2020, when the impacts of COVID started to occur, and you started to see that impact occur in enrollment. And you're seeing large increases in the Medicaid enrollment really start to take hold around March of 2020. And that basically coincided with the national shutdowns that you saw across the country, unemployment starting to rise, and basically that counter-cyclical effect started occurring on the Medicaid program. And to the extent, based on our chart we have here, that's Medicaid enrollment, also includes CHIP enrollment up through June of 2020. Based on the time period from February to March of 2020, Medicaid experienced a 6.2% increase in enrollment. And that's just a huge increase and something that's very difficult for states to absorb. That equates to approximately 4 million new recipients just flooding the Medicaid marketplace or flooding Medicaid rolls across the country in the program. In response to this, as you can see on the chart here, the federal government reacted to this and tried to help buffer this increase because they knew this was going to place some detriments on state budgets and some pressure there. They react by passing the Families First Coronavirus Response Act, which added some additional federal funding to states to help states manage this increased cost associated with this large influx of Medicaid enrollment. Now, going forward, I can expect that, or we can all expect that Medicaid enrollment is going to most likely continue to increase. Again, this is a snapshot up through June of 2020. We expect it to increase, and some of folks on my team have published some recent reports showing that Medicaid enrollments are now approaching 78 million. And with that level of enrollment, it's going to be placing additional pressure on states' budget. And I'm going to talk about some state budget issues that could be popping up here in a few slides. So this slide is going to just depict to you a few of the specific state examples to give you an idea of the level of increases that states are having to absorb in their Medicaid programs. Because just as you recall, as revenues decline from a state's perspective, these Medicaid enrollments occur. And so the enrollment cannot occur at a worse time from a state budgetary standpoint. And so this is a snapshot of some of the states that have reported enrollment increases since February of 2020. This was taken around the early September. And you can see large double-digit increases in many of the 11 states that are shown here. This is a large difference in recent years where states have experienced very modest Medicaid enrollment growth, and where those modest enrollment growth were budgeted into the 2021 state budget years to be able to fund the program. They did not expect this type of enrollment increase. About the biggest or largest enrollment increases that states were expecting at the time they were developing their 2021 budgets were those states that were doing Medicaid expansion. And so they were able to project the number of recipients coming in. COVID has just exacerbated that. Again, experts anticipate that the Medicaid enrollment is going to maintain these types of levels all the way into 2021. It's going to put a lot of pressure on these states. So as I mentioned, COVID-19 has placed a significant impact on state budgets. States are experiencing double-digit declines in revenue. What you see here on this particular slide is an excerpt from a September publication by the National Conference of State Legislatures. They're one of the leading associations in the country that tracks individual state budgetary actions. And this shows the level of impact to state revenues from COVID-19. At the time of this report, states were depicted in dark red on this sheet. They were reporting double-digit declines in state revenue, putting a ton of pressure on their state budgets. You've got on here 4 states like California, Colorado, New Mexico, Wyoming. All were reporting at the time of this report declines expected greater than 20% in their state tax revenue, putting that pressure on their budget. You had 3 states like Oklahoma, Kentucky, New Jersey. They were reporting declines between 16 and 20%. 14 states were reporting declines between 11 and 15%. And then you've had 18 states on this list or depicted on this map with declines anywhere from 1 to 10%. Now, again, this snapshot was updated in September. We would expect this to continue to be updated throughout the year. There are 12 states on here that did not report anything. Those are depicted in gray on the report. So you would expect that they are experiencing some type of decline in their revenue today as well, given that enrollment is up so substantially across the country. To just give you an example of how large those deficits are, a 21% decline or a 21% deficit in California would equate to approximately $42 billion. California operates right now on a total state budget of around $202 billion. Also, in a state like New York, a deficit of around 13%, which is what New York was reporting at the time, would be about $23 billion. And then in my home state of Florida, a 10% deficit would be somewhere around the $9 billion range. And so, as I mentioned earlier, in response to these deficits, the federal government reacted with passing the Families First Coronavirus Response Act. And it included that additional federal matching funds for these states to try to manage these increases and these budget impacts. You're going to see on the next slide that I cover, where I talk about some independent decisions that states are making, that the funds associated from the federal government from the Families First Coronavirus Response Act is not enough for the states to manage these impact on their budgets. And so it's going to make them have to have some very difficult decisions going forward, and especially in their Medicaid programs. For those of you that are familiar with Medicaid and state budgets, Medicaid typically is the second most expensive or largest piece of a state's budget, right behind education. Medicaid usually accounts somewhere around 20 to 25%. Some are even in the high 20s as a proportion of a state's overall budget and their spending. So there's always, anytime you have budget pressures, there's always a lot of pressure on the Medicaid program to try to assist some way in mitigating that pressure. Some specific state budget impacts, what I'm calling some of the states that are currently out there talking about potential Medicaid cuts to their program. We've got California. The governor there is basically cautioning and calling out to the federal government that they need additional federal funding, and they're going to have to cut reimbursement rates to providers and possibly optional Medicaid services. They've already reversed plans in California to extend Medicaid coverage to seniors who would otherwise be eligible except for immigration status. And they've delayed some delivery system enhancements that they were going to do. The governor's basically said these broad cuts in Medicaid provider rates are going to have to take effect next year, depending on where the next budget report comes in. And in Colorado, they're implementing a 1% cut in payments to physicians and outpatient clinics. They're implementing cuts in payments to children's and teaching hospitals, cuts in dental benefits, increased co-payments, and are delaying also some planned customer service improvements. In Florida, the governor's been able to get by so far with just vetoing increases in payment rates that were in the budget, but it's my understanding some Medicaid cuts and proposed cuts are going to be coming down the pipe very soon in Florida. In Nevada, they've done a 6% across the board cut in payment rates for hospitals, physicians, behavioral health providers, long-term care support services. Utah has reversed some plans to provide 12-month continuous eligibility for Medicaid children up to age 6. I know that's been a priority to a number of states, especially after Medicaid expansion, is to try to provide that continuous eligibility and a continuum of care to children on Medicaid. They're also cutting hospital rates in Utah. They're also cutting rates to managed care plans in Utah, or what we call accountable care organizations in Utah, and then some rates for some behavioral health services there. Tennessee reversed some plans to seek a waiver to provide Medicaid coverage for a year. Again, another one of these 12-month continuous eligibility. This one is for women after they have given childbirth. So that was an expanded coverage that they have reversed their plans on. and they were going to extend dental coverage for pregnant and postpartum women and expand access to services with people with intellectual and developmental disabilities. And so they've had to reverse those plans at the moment. And Washington is also exploring cuts in Medicaid services such as adult dental, school-based services, and some Medicaid coverage for certain immigrants. So again, states are very active right now in trying to manage their Medicaid budgets. I can say that in my experience in Florida Medicaid and managing Florida's budget, there is going to be significant pressure on these agencies that manage the Medicaid programs to try to rein in their spending at the same time that state revenues are going down. We're going to continue to monitor these in the upcoming months. Basically, in my experience, states typically look in two options when they start looking for cuts in the Medicaid program. One, they try to tighten up their utilization controls. So something like preferred drug lists or for the drug industry, or increased prior authorization requirements, things like that to kind of tighten down utilization. Those are some of the first things that they look at trying to do. Another thing that they really look to do is what you're seeing here on this slide is they cut provider rates. That's one of the most immediate things that a state can do to try to save money. And we all know that Medicaid provider rates at this point in time, their reimbursement rates are not that great to begin with. And so the last thing that you want, especially in an economic downturn, is your revenue as a provider to go down because of a provider rate cut. So a lot of things going on in the Medicaid program when it comes to budget, enrollment, etc. So what I'm going to do now is going to kind of shift gears over to some more of the update type stuff specific to Medicaid. We'll start talking a little bit about high cost drug reviews. This is something that we have seen here in the last few years, where there's been basically a target, or I would say a lot of focus on new drugs that have hit the market that are very high cost, and states have and state legislatures have tried to recognize this. This is something that I reported on last year at last year's meeting as what states are doing. The basic concept is that the state will pass some piece of legislation or administrative direction to the agency that handles the Medicaid program that basically has these three pieces in a basic concept. Now, these not specific to any states. Every state has their own concept of how this works. But what I've tried to do is depict on this slide, just in general, what the state is trying to do. And they're directed to basically enter into negotiation with drug manufacturers. Well, before they even do that, they're directed to identify high-cost drugs. I know the state of New York, they have a specific process. Massachusetts has a process, and there are many number of other states that have this type of legislation. They haven't quite been as aggressive as these two states yet. These are the two that most everyone in the industry are talking about. But there are a lot of other states that have similar administrative rules that they're developing or have had similar legislation passed. But basically, they identify high-cost drugs, and they have a way that they go about doing that. And they reach out to the manufacturers to try to negotiate a price and lower the price via rebates or supplemental rebates. And the concept is that they can try to reach negotiations. And if they fail to reach an endpoint of that negotiation, they can then refer that drug over to a public committee to where what I call occurs the, quote, name and shame part of the process. And so what that will begin to do is in a public forum, the state typically designates a committee that will review the drug. They will get outside input on the drug, and they're looking for a value of the drug. So in a public forum, they will have individuals that will present to them, experts in the industry, entities like an ICER that will provide the committee information about the drug and estimates of what the actual value of the drug is. And then it's up to that committee to basically come forward and say, okay, this particular drug should be worth X amount of money in the Medicaid program, and this is the price. And then they give the manufacturer the opportunity to defend their pricing information and so on like that. And so they use that as leverage to try to get additional rebates out of the manufacturer, assuming that the manufacturer would not want to go out in the public forum and have this debate with the state. And so I can tell you from experience, it's something that our firm here deals a lot with manufacturers. These states have been successful avoiding having to go down this road to go to the committee. There have been a lot of rebates agreements that have occurred between these states and manufacturers. But just to give you an idea, there have been a couple of drugs that, and all this is public information that's out there, that have been through the actual committee process where they've had to defend their pricing, or maybe some choose not to engage in that, but it still ends up being in a public review. The state will push it through the public review. The manufacturer has that option to engage during that public review if they'd like. And you can see there's been in New York 3 drugs. So it's not like a lot of these drugs make it to this process, but there has been 3 drugs that have made it through the process in the state of New York. All rebate contracts are kept confidential. And so with regards to these 3, I'm not going to comment as to whether or not any of these manufacturers ever entered into an agreement or not. That's between the manufacturers and the state. But we do know from public information that these 3 went through the process. In the state of Massachusetts, they are identifying drugs that they consider high-cost drugs, and they're in negotiations with many manufacturers. To date, I'm not aware of any drugs that have been sent down to that committee there. But again, this is just to demonstrate to you things that states have been trying to do to control the cost of drugs in their Medicaid programs and try to leverage some way, shape, or form outside of trying to put together a competitive environment against drug. This is an alternative way for them to try to reach an agreement between a manufacturer and the state to lower the price. One of the most impactful trends, and I reported on this last year, is the implementation of single PDLs and pharmacy benefit carve-outs. Single PDLs are where a managed Medicaid plan has to follow the same preferred drug list that's developed in the Medicaid fee-for-service. The state will dictate to those managed Medicaid entities that they have to follow that. And last year, when I reported, there were 13 states that operated single PDLs. As of 2020, 18 states, and these are increasing as we go. A pharmacy benefit carve-out is where the state has decided to pull the entire pharmacy benefit away from managed care, and the state is going to actually manage the entire pharmacy benefit. That not only means manage the preferred drug list, but that also means processing claims and PA criteria, et cetera. And that is also a recent trend. You can see on this sheet here where I've got 2 very large states that are heading that direction, the state of New York and the state of California, that are in kind of the light gray color. They haven't quite gone dark gray yet. That's because they haven't implemented them yet, but they are heading towards pharmacy benefit carve-outs. California, January 1, 2021, and the state of New York, April 1st, 2021. Then you've got other states here that have implemented what we call select drug carve-outs or class carve-outs, and I've gone through all these states to include those states that are carving out hemophilia agents from managed Medicaid plans. So again, a recent trend, we see it continuing. It's been growing for quite some time. And I've got a little timeline here that I can share. Again, all these updates since last year when I spoke to you guys about this that's going on. So you can see across the top, we've got the single PDL timeline of implementation of all the states, started back in 2013 with Kansas and Texas, and so on and so forth as we've come up into 2020, where we've had 3 states decide to go to single PDLs. Four states implementing single PDLs in 2020, and we've got one on the docket January 1, 2021 in Kentucky, requiring all their managed care plans to follow the same PDL as fee-for-service starting January 2021. When it comes to carve-outs, we've got several states, again, Tennessee, Wisconsin, Missouri have been carved out for as long as I can remember. Then you've got West Virginia in 2017, North Dakota implemented in 2020, and now we're looking at the state of California and New York going to a full pharmacy benefit carve-out away from managed care in 2021. Another update that I wanted to provide today was with regards to Hemophilia Factor. Okay, the last time we spoke, this is a new trend that we're seeing among states in the Medicaid program. We are now up to 20 states that are including hemophilia factor as part of their preferred drug list. Now, some of these states just make hemophilia factor preferred across all of the drugs on their PDL. But the key is that to know that they're now moving these over to the PDL, and the PDL is put in place to manage drug utilization. So as I've always mentioned before, states take baby steps in managing, and I think the states are going to get some more pressure given the budget impacts of COVID-19 to start doing this going forward. But I think the last time I reported to you guys, there were either 13 or 15 states that reviewed hemophilia factor as part of the PDL, and in 2020 that has now increased to 20 states. And then we still have about 21 states that operate just open access. They don't review hemophilia factor or hemophilia agents on their PDL. They just have open access coverage criteria. And then we've got about 7 states out there that operate clinical prior authorizations, which is basically open access. If you have a diagnosis, then recipients can get the drug. And then we've got Hawaii and New Jersey, who basically delegate their entire managed care or their entire Medicaid population to managed care. And then California, I kind of separate out because it's managed under its own program, under the genetically handicapped persons program, but it can be restrictive to some agents. Good update here on what's going on since the last time we talked in 2019. So here we go. Let's specifically talk about hemophilia. Okay. Hemophilia factor is on the PDL in 20 states, as I mentioned. And when it is reviewed as part of the PDL, what I'm seeing is there are a handful of states out here, I'll talk about in a second, that just cover everything, all products. But there are states that are implementing preferred and non-preferred criteria associated with coverage on the PDL. And that's the standard methodology that states use. When you look at these 20 states, they all have preferred, non-preferred criteria, with the exception of Alaska, Illinois, Texas, and Washington, where they prefer all agents. The states that operate non-preferred criteria, basically it means you have to have documentation of medical necessity of why you need the non-preferred drug, or they may implement a failure of one or more preferred agents. But we have seen many states, as they move these classes over to the PDL, implement grandfathering clause. I think last time we talked 6 of the 20 or 6 of the states that had PDLs or hemophilia on the PDL were operating grandfathering clause. We've now updated that. There are 7 out of the 20 that have some type of published grandfathering or some type of look back clause to see if that recipient has been on that agent to allow that prior authorization to go through in that PDL circumstance. Another reason why I went through the previous slide about the single PDLs, and that's why that's very important to understand, is that out of these 20 states that are reviewing hemophilia factor products and making certain products preferred, certain products non-preferred, 10 of these are in single PDL states, and they're requiring these managed Medicaid plans to follow the PDL in those states. So that's why that becomes very important. A little timeline here of when factor or hemophilia agents have been added to the preferred drug list. This started in 2009 with the state of Maine and has gone forward. And you can see in 2020, we had a lot of states add this class of drugs or agents to their PDLs, as we see here. This is mostly driven from what I determine is the PDL vendors that you see down here at the bottom. The 2 main vendors in the country are Change Healthcare and Magellan Medicaid. You can see Change Healthcare is the PDL vendor for 12 states. A PDL vendor is responsible for giving the state its recommendation on what drugs to be included in the PDL, et cetera. And then you have Illinois down there that decided to make the move in 2020, but Illinois doesn't operate a PDL vendor. Just a snapshot on those PDL reviewed states that review the class or agents for the PDL. What are the most commonly preferred products out there that we're seeing? Now that these drugs are being on the PDL. We took a sample of 34 products, and basically what we're finding is states vary on the classes of blood factor that they review. Some might review only factor 8, some might review factor 8 and 9, some might review all of them as we looked at each state individually. But the most commonly preferred products are listed here. You can see 20 out of 20 states prefer or have the agent Advate in the preferred position and benefit fix in the preferred position. 19 states out of the 20 have Novo8 and Wilate and Zentha in the preferred position, and then 18 states and down, so on and so forth. I won't go through the list, but again, these are just the most commonly preferred agents across these 20 states. You know, they could be they could different depending on the state. You can have a different mixture. So I'll give you just a moment and you can take a look through that. So this is a slide that I really like to show every time I do this update. And I think it really sets up the risk for hemophilia factor. And I think some of the things that I've always harped on in the past is I felt like we're going to see more management of hemophilia factor because it's always one of the high drug spends in the Medicaid program. And we've seen that over the years that I've been working with NHF on this project. It remains the number 3 highest net spend class in the Medicaid program, and high expenditures always equal utilization controls. What are utilization controls? They're things like preferred drug lists, they're like reimbursement changes, or there's network controls. Those are the typical things that states can do to manage drugs. And whenever I say preferred drug lists, I also include leveraging for supplemental rebates. Very similar to things that we're seeing like that. Well, that's the impetus or the reason why a PDL is created. Is to manage utilization and then also try to lower the cost of the drugs through leveraging supplemental rebates out of manufacturers. But we are also seeing other states like the high cost drug states like New York and Massachusetts trying to leverage the public forum to try to avoid that. We also, in the hemophilia space, we have 3 of the top 10 drugs in total Medicaid net expenditures. You've got Eloctate coming in about number 6, Hemlibra, and then Advate at number 9. So always a target in this space. That can also be demonstrated or shown in a recent trend report that was provided by Magellan Medicaid. Magellan Medicaid manages 25 state Medicaid pharmacy drug programs across the country. They have the largest population of lives across the country that they manage on behalf of the states. And if you look at their recent trend report, pulled a quote out of there, it basically says specialty growth continue to drive its increasing trend and is rapidly approaching a forecast we had made since the first edition of this report in 2016, that specialty drugs will account for 50% of net drug spend in Medicaid by 2020. And in 2019, specialty accounted for 48.5% of net spend while making up just 1.3% of the overall utilization. So I thought that was a significant point that I took out of this report. Again, I wanted to depict to you excerpts out of the report that you see on the little pie chart where hemophilia in this report within the Medicaid or Magellan Medicaid states is identified as number 3 and take up about 7.5% of net cost of drugs in Medicaid. And you can see the definition of Medicaid net drug expenditures or net cost over there is pharmacy payments, and then subtracting out any and all rebates. So another precursor of something that you need to look out for in the Medicaid space. Another quick update here, something that I've always reported on with regards to hemophilia factor reimbursement. I'm not going to go into all the other states, but the big point here is that in 2020, many of you probably know this, Medi-Cal finally approved their blood factor reimbursement rates. So the rates are basically depends on whether or not you're an HTC or a specialty pharmacy. Essentially, the reimbursement here, I'm sure everyone's going to have a copy of the slide, but essentially the reimbursement here is ASP plus 20%. So I know everybody was relieved to finally see that this got implemented. I know this was ongoing. It was the very last state to finally publish out their state plan amendment for factor reimbursement. So it's good to see that finally happen in 2020. So that has occurred since our last update. Update on some other pieces of the project with regards to exclusive provider networks and types of management programs. We're still seeing these programs operational in Alabama, Florida, North Carolina, Oregon, Pennsylvania. South Carolina, Utah, Washington, and Wisconsin when it comes to operating these types of provider networks that are out there. When it comes to management programs, we're still seeing them operate in a number of states. When I say management, I'm talking about comprehensive type hemophilia management programs in Alaska, Alabama, Illinois, North Carolina, Washington, Florida, Oregon, South Carolina, Utah, Wisconsin. Since our last update, nothing has changed here. So I just want to reiterate that these programs are still operational. So let's look a little bit to the future here as we get close to the end of the slides, and I want to save some time for some questions. So 2021 and going forward, we're going to see the implementation of some significant states that are going to implement single PDLs and carve-outs. Again, who's going to control the drug coverage decision, and who's going to control that decision for Hemophilia Factor and other hemophilia agents? And in Kentucky, as I mentioned, January 1st, 2021, they'll implement their single PDL. Medi-Cal, a huge program, will carve out their entire pharmacy benefit. Now, I know that the GHPP program operates the hemophilia side of things. So essentially, there's already a carve out. So with regards to hemophilia, largely in a way unaffected there, but still a significant change in Medi-Cal, especially when it comes to drug manufacturers. New York, perhaps the largest impact. All those managed Medicaid lives, their pharmacy benefit is going to be controlled through fee-for-service and the Medicaid agency. And so what does that do? If you're a recipient and you're worried about your drug benefit, or if you're a provider and you're wondering who the prior authorization entity is going to be, that or who's going to pay you for the drug, and if you're a manufacturer, who's controlling the lives and access to the drug. And so on the left-hand side, if we just look at Medicaid based on where all the Medicaid lives are, where they receive their benefits, 73% of all lives in Medicaid today receive their health care benefits through managed Medicaid. And about 27% receive that through fee-for-service. The key when it comes to drugs or the pharmacy benefit is to understand who actually is controlling the pharmacy benefit. So I've already been through and talked about single PDLs, whole class carve-outs, entire pharmacy benefit carve-outs. So when you start looking at the Medicaid space and the recipients on Medicaid, and you adjust for that, who is controlling their pharmacy benefit, it basically totally reverses the population. And what we call this is state control of the pharmacy benefit, to where 76%, once these other three states kick in, Kentucky, Medi-Cal, and New York, in 2021, 76% of all the lives in Medicaid, their entire pharmacy benefit coverage will be managed by the state. So that means through single PDLs, the states will dictate which drugs are preferred and which drugs are non-preferred. The same thing will happen with a pharmacy benefit carve-out. The state controls that access to that drug through fee-for-service. So 76% will be managed by the state. It will largely, the managed Medicaid plans will see a reduction in how they have to manage pharmaceuticals going forward. So very interesting times in Medicaid going forward when it comes to managing pharmaceuticals. In 2021, things to look for. Again, I mentioned budgets. So manufacturers are going to receive pressure to provide additional supplemental rebates. PBMs are going to try to keep the net cost of drugs flat. We've seen a lot of letters come out from PBMs. We're going to see new categories being reviewed for preferred drug list. As recently as just 6 days ago, Texas moved 5 classes to the PDL, some classes that you would never think that Texas would manage: hemophilia, anticonvulsants, HIV meds, and oncology. And then states are looking at these pipeline drugs. Again, specialty drugs continue to be a problem for them. 1.5% of the utilization, but 50% of the cost. I mean, just huge increases there. And then gene therapy agents on the horizon. I know that manufacturers are actively educating states on pipelines of gene therapy, and states are worried about the cost of these drugs. One thing that has come out in the recent years are these value-based agreements to try to help mitigate that. But I can tell you that we're seeing some slow uptake on those. There are some across the country, but they haven't quite taken a hold like one would want or one would expect. There's a lot of things that states have to work out with that. And then effects of COVID-19 are going to continue in 2021. Medicaid enrollment is still going to be high. State budgets are going to have pressure. State tax at the same time. Enrollments are high. Tax revenue is going to go down.
So the first question is, how does 340B fit into the high cost drug review?
That's a very big question.
That's why I left it for you.
Very difficult question to answer. I don't know if I have the best answer for that at this point. The whole reason for the high cost drug review is to leverage supplemental rebates. So I would expect that if a state, if one of these states gets into one of these agreements for supplemental rebates, that they're going to have to change how they manage 340B reimbursement, because on its face, 340B has already accounted for Medicaid rebates in the actual reimbursement. I would think that the state would have to do some type of adjustment to that for 340B providers if they were to enter into these rebate agreements with the state. But I don't have a clear answer. I don't have a drug that I represent that's been through that process yet, but that would be something that I would be thinking about as I develop that rebate agreement.
Then the next question is, how do carve-outs of pharmacy benefits help or hurt our community members?
It kind of depends on the state, right? So if your member is in a managed Medicaid organization and they have access to their drug and they're getting good access to the drug, to the extent that state removes that pharmacy benefit away from that managed care, and let's say on the fee-for-service side, the state has that same drug covered, but it's non-preferred. It requires prior authorization, it requires some kind of step edit, etc. That's where you enter into some type of problem. Okay, that's the difference. That's the risk that you have. Now, when states make these moves, they typically like to honor the prior authorization that's occurred from the managed care. As the shift goes, they don't want to interrupt the recipient's care or interrupt their drug coverage. But once that shift has occurred after a period of time, the state is going to revisit that prior auth and look at it really hard to see if a preferred or least costly agent could be reviewed. So that's the risk you run into when states are moving things from one side to the other.
It comes down to what I think you're saying is how the process is written, right? What is the process to get to the drug, which is non-preferred?
At the high level, it's a comparison of how is your drug currently covered on fee-for-service versus how's the drug covered on managed Medicaid. If they're covered the exact same, then there is no risk.
Right.
If your drug is on managed Medicaid and you have good access, but the coverage criteria on fee-for-service is more restrictive, then that's when you bear some risk.
Okay, and then the next question is, so Factor is currently covered under the medical benefit in their state. Will that be impacted by a single PDL?
Depending on the state, but the answer is typically no. Medical benefit drugs are typically not covered or not affected by preferred drug lists.
Is that universal? Oh, sorry, I think Michelle.
The universal answer is that typically medical benefit drugs are not affected by preferred drug lists.
I guess, Matt, this is Michelle. Nice to see you.
Hey, Michelle.
So on that question about medical benefit, and let's say this is Kentucky, and Kentucky is just talking about doing a single PDL. I mean, are you finding that in many states the Factor is covered under Medicaid? It's usually through the pharmacy.
Correct.
Yeah.
Typically, no. It's very rare you see them bill through a buy and bill medical benefit. It's typically always specialty pharmacy.
That's what I thought. I thought. And then the other question is, you were just talking about the risk with, going to the state's preferred drug list, the single preferred drug list. And I think what we found in many states is that the prior authorization process is you usually experience more denials in that through the managed care side than you do through the state, through the fee for service side.
Yep.
And so I think we've always had a preference really at NHF for it to be over in the fee-for-service side because of the fact that the managed care plans are capitated plans. So they usually do make the hurdles a little bit harder to jump through and usually have more, restrictive policies too, I think, than the state does.
Yep, you're absolutely correct. Managed care plans are typically the most restrictive entity that you deal with in Medicaid, especially for hemophilia factor. As I flip back to this slide, you can see a lot of open access across the country for hemophilia factor, no restrictions. And a lot of these states that operate the PDLs either have, like I mentioned, grandfathering clause, or they've just preferred all the agents. So yes, fee-for-service is typically less restrictive for hemophilia factor than managed Medicaid at this point.
I have one clarifying comment I wanted to make and one more question. The clarifying comment has to do with California Medicaid. And while I know that their rule was passed, I think it's important to note that the way it was passed was the lesser of. And so really ASP plus 20%, is not going to be the lesser of if you are a specialty pharmacy, because for specialty pharmacy, it was their purchase price plus 4 cents, right?
Yeah, that's correct. If they're still viewing the screen, I flip back to that slide. And so you can see that on the bottom half of the slide here. It's the lower of for specialty pharmacies, the lower of the provider's actual acquisition cost plus a 4 cent per unit, or ASP plus 20.
Yeah, we know that only because we hear lots of crying. Sorry for anybody from California. I mean, on behalf of the specialty pharmacies.
Yeah.
But then the other question I had was, when you were looking at the big net spend, right, or the highest net spend, and like, I think Hemlibra was number 8, Advate was number 9. That's the cumulative spend though, right? Which also probably illustrates how many people are utilizing that product.
That's
not
true.
necessarily just because it's higher cost per unit, right?
True. That is true.
Okay.
It's cumulative cost.
Okay.
That is true.
Just want to make sure.
Yeah, I was trying to find that slide again.
By the way, I love that new slide. I don't think you'd done that one for us before, right there. That showed the product and right there on the how many states prefer it, and I think that's very helpful.
Good.
So a follow-up question from the woman in Kentucky. So if there are less restrictions with fee-for-service, how is that a cost saving?
Well, it may not be from a state's perspective at first, but typically the reason why states move these drugs over to state single PDL is to leverage more rebates. Yeah. And so from a state's perspective, they not necessarily looking at it from a cost savings, although they're going to try to get some through leveraging rebates and managing it on the PDL. But they also look at it from a continuity factor for prescribers across their state. So now prescribers are prescribing off of one uniform preferred drug list versus before a prescriber might have recipients coming to them from many different managed care plans throughout the state and having to prescribe by specific managed care preferred drug list for those in each one that's different for each individual. So those are the main reasons why states do it.
And Tracy, you're asking a good question there about, yes, it would become a discussion between the 340B program and the state Medicaid program and through fee for service, and what the issue is there for you. And this is the one negative for HTCs, I think, is that some states will, some managed care plans welcome 340B. In some states, in their fee for service plan, the state will say, you know what, we'd prefer you, if you go with 340B, it causes your reimbursement to be much lower. It's just your cost plus a nominal dispensing fee, unless they do some sort of waiver program. Or what they'll say to you is, we'd prefer you provide to us out of non-340B inventory. That happens a lot. And so I could have that conversation with you offline, but I will tell you that's one of the reasons why some 340B programs don't like working through fee-for-service Medicaid, because if the Medicaid office isn't willing to do some sort of waiver where they agree to pay you so many cents per unit or whatever, they will pay you just your cost plus a small dispensing fee.
And with that, we are at time, and I want to thank Matt, and I know Michelle wanted to give some closing words on behalf of NHF. But we thank you, Matt, for all of this information. It's a lot, and we thank you for sharing the slides with us. And I personally want to thank you guys for coming to my first virtual conference. I hope you all enjoyed it. I was thrilled we can expand it out using the virtual platform, and I really hope everyone benefited from it, at least some. And thank you, and I'm going to turn it over to Michelle.
Honestly, I was just also going to say the same thing. I want to thank everybody for joining. We've had excellent attendance. Hopefully everyone has found the information useful. And Matt, we were just talking yesterday about doing some additional webinars for social workers in the future. So don't be surprised if we don't reach out and ask you to do a few more things for us. So thank you all. And thank you, Marla, for doing an amazing job. And Joanna in our Conference and Travel Services Department.
Joanna Ong, high applause for her, who
Yes.
She is not speaking, but high applause for her. Without her, it would not, none of this would have gone that well. I don't have that kind of patience, but we appreciate her, and we appreciate all of you. And with that, we conclude Insurance Conference. Yay!
Yay, thank you.
Thanks, guys.